Good evening, everybody. Today's topic is going to be about hypersensitivity reactions. And in this topic, I think we are going to take two sessions to cover this important topic. We will start by talking about the theoretical aspect of allergies, some definitions, and what do we mean by hypersensitivity reactions, types of hypersensitivity reactions, and very important, we will talk about some clinical examples of allergies. And then we will talk in details about how we can make a diagnosis, or before that we'll talk about the pathophysiology, of course, and diagnosis, clinical diagnosis, as well as here the laboratory diagnosis of allergies and hypersensitivity reactions. These are the most important objectives that I want you to know. We will start by what we call the Gill and the Coombs classification of hypersensitivity reactions. And then I want you to give two examples of infections that are responsible to cause different types of hypersensitivity reactions. We'll talk about those in just a second. And then you need to give three examples of how normal innocuous substances may cause allergies. And finally, I want you to know about how to contrast the two different here skin tests that we do here in order to make a diagnosis of allergies. So this sketch will summarize what we are going to talk about, the hypersensitivity reactions, the four different types, and we will talk about them in just a second, and the etiological agents and how we get this type of a disease, like for example the agents that are responsible for allergies, like infection, and very common harmless environmental substances, and then the self antigens, or like an autoimmune phenomena. And I want you to know the four different types here. The type 1, here hypersensitivity, which is the immediate type. We call that the anaphylactic type, or the IgE mediated type. And then the type 2, the cell-bound antigens, and an antibody, usually of the IgG type, binds to cells, and then complement will be activated. I'm sure you know about all of those. We have discussed in the microbiology class. And also the type 3, the antigen antibody, they form complexes, and those they precipitate in tissues, and then complement will be activated. And type 4, which is the delayed type hypersensitivity reaction, that usually takes more than 2 to 3 days in order to take action. So hypersensitivity reactions or allergens, what does that mean? Just simply, it means an excessive immune response that causes damage to tissue. Ziad Elnasser saying this is where it's an overreaction to a certain substance, and this reaction is going to mediate an inflammation that will inflict injury into our tissues. So another word for hypersensitivity is allergy. And so the word allergy, it's a term that originally here meant any here altered reaction to external substances, yani substances from outside, usually that makes changes into our body. So those excessive then immune response could be caused by infectious agents. We'll talk about that in just a second, like the, for example, rhino viruses and the common cold. You'll see how you will get edema and the stuffing nose and so on. We will talk about also the hepatitis B virus, for example, and many others. And also the most common ones are the environmental substances, where people, they could be allergic to dust, for example, and of course the pollens here of plants and so on that usually are present in the air in certain seasons, and now is the season, the spring time, for example. And sometimes here we could be allergic to self antigens, and this is part of what we call the autoimmune phenomena, and we will be talking about that among what we call the autoimmune diseases, and what are the autoantigens that could inflict injury in our body. Remember the four different types and the mechanism of injury: type 1, 2, 3, and 4. Type 1 is the IgE immediate type, the fastest, the one that causes anaphylactic shock. We'll talk about in just a second, the IgE mediated. Type 2, which is the IgG mediated, the antigen is on the cell surface, antibody binds, and then complement will be activated. Type 3, antigen antibody reaction forms immune complexes that precipitates in tissues, and complement will be activated. And type 4 is the delayed type, hypersensitivity reactions mediated by here the T type. We'll talk about that in details. So the infectious agents that are associated with allergies, so important for you to know. Remember the common cold. Here, when people they get the common cold virus, usually have stuffing of the nose, like edema, running nose, and so on. This is a type of allergy. And the influenza virus, here the same thing here. The difference between the common cold and influenza, they are of course two different viruses. The influenza virus is associated with more severe type of a tissue damage compared to the common cold virus, and fever also will be associated with the influenza, but the same thing here, you will be getting edema and all the signs and symptoms related to allergies. And during here the infection, cytokines are going to be released, and those cytokines are the ones responsible for the signs and symptoms that you are going to see in these diseases, and we call those the cytokine storm, responsible for all the signs and symptoms of the patient's suffering, for example. And very important to know that when these cytokines are released, they could go into other organs in our body. So you will see that here in such types of infections where cytokines are released, remote areas in our body are going to be affected because these cytokines could travel from one area into the other. So the severity then of the allergies or hypersensitivities related to those infectious agents has to do with the amount of the infectious dose that is usually enters our body. So it's extremely important here to know that the infectious dose is directly related to signs and symptoms. The second important thing in all of these allergic conditions is the genetic factor. So certain people are susceptible to develop allergies compared to others, like hepatitis B virus or Streptococcus pyogenes, for example, bacteria and allergies. To that, we will be talking about that later. And also we will be talking about the environmental substances that are present sometimes in the air and then we are exposed to, that will cause the production of these cytokines, and usually those are so small, so easily they can enter into our respiratory tract, and those usually they induce the production of an IgE antibody, and this is the one that's responsible for anaphylactic shock. We'll talk about that in just a second. And some others, they could be responsible for the production of IgG antibodies. So these IgG antibodies could form complexes that they could here precipitate in the different tissues, and then complement will be activated. Very important to know that sometimes we could have haptens could be responsible, and the hapten, as you know, is a substance on its own that cannot induce an immune response, but when it is hooked into a protein carrier, then it's going to produce an immune response against the hapten as well as the protein carrier. And of course, certain drugs could be responsible for hypersensitivity reaction, and we call that in idiosyncratic drugs. So many drugs could induce hypersensitivity, like antibiotics, penicillin, for example, and many others here that could lead to death. So remember always the drug reactions. So we have two terms that we will be using, allergy versus atopy. Allergy is here the process of hypersensitivity that we are going to talk about here. Versus atopy, we mean by that is the genetic susceptibility to get type 1 hypersensitivity reaction. So when I say atopy, that means this patient has the genetic susceptibility to develop usually type 1 hypersensitivity reaction. Remember that when a hypersensitivity reaction is mediated against self-antigens, we call that autoimmune diseases or autoimmune reaction, and we will be talking about that in a separate lecture. So this is just more details of the 4 different types of hypersensitivity reactions that you should know in details: type 1, type 2, type 3, and type 4, and the immune mechanisms that is involved. So in type 1, usually it occurs in seconds. FIGE is preformed, and if it is not, usually it takes much shorter time here compared to others. While type 2, for example, seconds, FIGG is preformed, but if it is not, it will take much longer. And here type 3, usually it takes hours, but FIGG is preformed. Usually it takes a shorter period of time. And remember that in type 4, the delayed type, usually 2 to 3 days it will take. And here, if the triggering is an infectious agents, for example, type 1, like the schistosomiasis, here this is a classical example. In type 2, here where the antibody is against cells, here usually the immune hemolytic anemias and antibodies against red blood cells. And the type 3, where immune complexes are developed, here like the post-streptococcal glomerulonephritis. Here, this is so important to know. And type 4, the delayed type, usually classical example is the hepatitis B virus. And then, so again, other environmental factors, very common is the house dust mite, feces, usually, where people they are allergic to, or some classical examples is the immune hemolytic anemias, and then complement will be activated, and then lysis of red blood cells is going to take place. And the classical example, the farmer's lung syndrome, where your immune complex is related to here certain plant seeds, pollens, and so on. Those they precipitate in the alveoli and cause pneumonia-like. They call it farmer's lung syndrome. And also in the type 3, or I mean in type 4, sorry, here like what we call contact dermatitis, where people they will develop hypersensitivity to certain metals, especially the ones like artificial jewelry, not gold or silver or something like that. And here, what about the autoimmunity? For example, in type 1, it's not applicable. Here, rarely we don't hear about allergies or type 1 IgE mediated against here self antigens. But type 2, the same thing, the immune hemolytic anemias, and the type 3, the immune complexes like SLE, systemic lupus erythematosus, and we'll talk about that, the DNA, anti-DNA immune complexes that will develop, and the here type 4, like for example the insulin-dependent diabetes mellitus, and we'll talk about the different theories related to that, celiac disease, multiple sclerosis, rheumatoid arthritis. All of those are related to cell-mediated immunity. And the adaptive immune mechanisms, like in type 1, it's the antibody is the IgE, the reagenic antibody we call it. Very important to know that. In type 2, it's the IgG, as well as the type 3 immune complexes, it's IgG. And type 4 is cell-mediated immunity, delayed type hypersensitivity type of a reaction. And the here the innate immune mechanisms that is involved. For example, in type 1, the type of cells that are involved are the mast cells that produces or secretes the mediators and stimulates the production of eosinophils. So eosinophilia usually is associated with type 1 hypersensitivity. And here in type 2, classical example of hemolytic here sorry, um, uh, the haptens, for example, and the phagocytosis, where the immune reaction here will call upon phagocytes to come into the area. So you will see in neutrophilia is going to be associated with type 2. Complement, it's the complement activation and phagocytosis in type 2 and type 3, the same thing, complement, and the neutrophils, the same thing here. Chemotactic factors are going to be produced, so neutrophils also will be produced. And in type 4, the delayed type, classical cell involved here are is the macrophage, and you will see. So in type 2 and 3, here we will see neutrophils and complement activation because of that. And in type 4, it's the macrophages. Remember, in type 1, it's the mast cell that has receptor for the IgE antibody, and degranulation is going to take place. So again, the types of hypersensitivity reactions, extremely important for you to know the immune mechanism and their classification, type 1, 2, 3, and 4. We call that the Coombs and Gell classification. It's based on the type of the reaction that is involved. This is so important here for you to know. And here, very important to know that a previous exposure is a must. So the first time when you here you get exposed to the antigen, you become sensitized. So it's a must that you be exposed for the antigen. And then when the second time you are exposed, then the reaction is going to be much faster. So here we see that usually the adaptive immune system are going to be involved, and then this is going to lead to the production of antibodies, for example, IgE, IgG, and so on. And here we will see that the innate immune response also are going to be involved here, where here PMNs also are going to be produced, and they could here play a role in the tissue damage when they are here stimulated. So I want you to remember that type 1, the antibody is IgE antibody, and the cell is the mast cell that has a receptor to the Fc portion of the IgE here. So the mast cell is the one that is involved, and then they will call upon eosinophils to come into the area. So we'll see massive eosinophilia, and we will see how they play a role in the damage, especially in bronchial asthma as well. Another name for it is the immediate type, or allergy, or anaphylactic type. That leads to anaphylactic shock. And we do the test that we do to test for that is what we call the skin prick test. The skin prick test to stimulate the reaction that is involved in this type. Type 2, the antibody is IgG here, and the antigen is usually on the cell surface, and then complement will be activated, and this is going to call upon here neutrophils to come into the area. PMNs usually are involved. That is going to lead to tissue damage. The type 3 here, where antigen antibody, the antigen and the antibody are soluble, so they form immune complexes that will precipitate in the different tissues, and complement will be activated. And this could be localized, we call that Arthur's type of reaction, or systemic, where the immune complexes could disseminate all over and activating complement. And the type 4 is the delayed type. This is the slowest type, usually takes 2 to 3 days, mediated by T cells, the delayed type T cell. And the test that we do, we call it the patch test. The patch test in order to make a diagnosis of type 4. So in type 1 is the prick test, and type here 4 is the patch test. This is so important to remember. So usually in type 1 hypersensitivity, here we have a clinical case that will show the exposure usually to pollens, for example, and how those which time of the year usually they will develop, and the signs and symptoms related to allergic rhinitis or bronchial asthma and so on. For example, this case is about hay fever or allergic rhinitis here. So a brother and a brother and sister, for example, growing up in New England, where they have lots of trees there, have here the tree type, they call it problem. They do have problems with running nose, and they develop hay fever, running nose, and here sorry eyes. They keep sneezing and here itching at different times of the year. Both of them here notice that symptoms here improve indoors. That means when they are inside the house, they are not exposing to pollens, they improve. But they return within minutes of going outside. And when they get outside, then they will start sneezing, running nose, and itching to their nose. The girl symptoms are worse in the spring time. So here the pollens usually they appear in springtime, but sometimes it depends on the plant. Some they form in the summertime. The boy have symptoms in the summer, so it depends on the type, as I said, of the plant. Some they form the pollens in the springtime, some during the summertime here, which has made him struggle here with exams. Skin prick testing, this is the test that we do to test, is carried out, and here you will see in chapter 27, for example, your book, how we do that in the prick test, the skin prick test, where it shows the edema and hyperemia that simulates the type 1 hypersensitivity reaction, because the wear and flare type of a reaction. And it confirms that the girl is allergic to birch. This is the plant here. Birch pollens, and the boy is allergic to grass. So both they are responsible for allergy, the grass pollens here. The chart here shows here why their symptoms happen here at different times of the year. So here, when you look into the graph, how the pollens, for example, for the girl occurs at the springtime, while in the boy in the summertime. It depends on the time of the year where they form a grass. So this is so important to know here about the different types of plants and which time of the year they form the pollens. These are the types of trees here. They call it the birch trees that they form the pollens. And this is the second type, and you can see the pollens that some they form during the springtime, and some, as I said, others during summertime. So people, they could suffer when they form their pollens. And so this is the skin prick test, and here you will show the wear and flare type of a reaction that will develop in response to the extract of the pollens that they are using. Of course, they use negative control and positive control, so to see that the test is positive or negative. So this second case talks about type 2 hypersensitivity reaction, and about a patient who is allergic to penicillin, and when he took a dose of penicillin, the penicillin here worked as a hapten, so it developed antibodies against the penicillin binding protein and penicillin, and then hemolysis of red blood cells are taking place, and how this patient developed anemia, and shows in the lab here loss of red blood cells and jaundice because of that. And the detected IgG antibodies here against the red blood cells are found to confirm the diagnosis. So this here sketch shows here what happened in that case. Here, this is the penicillin, and the penicillin is so small, and on its own it cannot induce an immune response. But when it binds into the red blood cell, here penicillin binds to a protein on the surface of red blood cells, so it will act as a hapten. So the antibody now is formed against the penicillin and the protein carrier at the same time. The penicillin now acts as a hapten and induces an antibody here production. So now you have an antigen and antibody reaction. Complement will be activated, and this is going to lead to the destruction of red blood cells, and then hemolysis is going to take place. So this again explains what has happened. Here, usually, if the patient is having anti-penicillin antibodies at this stage, this is nothing is going to take place. But when here the patient is exposed to penicillin and in a secondary immune response, and more antibodies are going to develop, and then these antibodies are going to bind to the penicillin and on the penicillin binding protein on red blood cells, and this is going to, as you can see, activate the complement and then the destruction of the red blood cells are going to take place. So here another example of post-streptococcal glomerulonephritis is taking place, and how a patient who is infected with the group A beta hemolytic strep and develops here sore throat and tonsillitis, and then months after being exposed develops here what we call post-streptococcal glomerulonephritis or rheumatic fever complications. And here you will see how this patient develops here the hay fever and the glomerulonephritis, and how the immune complexes that develop, they precipitate in the kidney, and then complement will be activated here, and then the kidney is going to be destroyed. Although you're doing just urine analysis, you might show here a normal finding, but this patient developed an immune response against the immune complexes that got precipitated in the kidney, and inflicted a kidney damage because of the immune response that had developed against the group A beta hemolytic strep. So this sketch shows here what happens in rheumatic fever, rheumatic heart disease, or rheumatic post-streptococcal glomerulonephritis. Here, when the immune complexes of the bacterial antigen and the antibody develops in their optimal proportion, immune complexes will develop that will precipitate in the basement membrane of the kidney, and then complement will be activated, and then the basement membrane of the kidney is going to be damaged, and the patient will develop post-streptococcal glomerulonephritis. But when the infection is cleared, as you can see here, the antibody level is so high and the antigen level is so low, so the amount of immune complexes will not develop in this stage, where here the antigen and antibodies, they are not in their optimal proportion, so no immune complexes will develop, and no signs and symptoms are going to happen. So in other diseases, like for example here with hepatitis or serum hepatitis, the same thing here will apply. The antibodies against the hepatitis B virus is going to be produced, and with the antigen they form complexes that they will precipitate in the different tissues, and this is the mechanism of the rash that will develops. Immune complexes and complement will be activated here in relationship to the virus production. Remember that the immune complexes, they develop in their optimal proportion related to the concentration of the antigen and the concentration of the antibody. So they form immune complexes and develops the blood vessels, so they form what we call vasculitis here on the skin, for example, and so on. So this clinical case shows a hypersensitivity reaction of type 4, the delayed type hypersensitivity reaction to certain grass weeds. Here they call it dandelion. Here, and how the patient develops contact dermatitis just when walking barefooted. And we'll see that the rash that will develop on the patient's feet here is related to the delayed type hypersensitivity reaction, or the type 4 here type of hypersensitivity reaction. This is, for example, the dandelion plant, and many people here they will develop delayed type hypersensitivity reaction related to this. So this is the dandelion plant here, where people usually they will develop allergy against, especially here the if they step on it, causing the delayed type hypersensitivity reaction or contact dermatitis. This is the patch test that physicians they do to see what type of a plant or allergen you are allergic to, and we use that for the delayed type hypersensitivity reaction or type 4. So they make like a map on the patient's back, and they put different types of plants, and then they will see the erythema or the reaction against which type. They call that the patch test for delayed type hypersensitivity of reaction type 4. So those are the main then objectives of this part 1 of the lecture. Explain the Gell and Coombs classification hypersensitivity reaction type 1, 2, 3, and 4, and you should know the details of each one of those, and give 2 examples of here infections that cause here different types of hypersensitivity reactions. We talked about the common cold and also the influenza, the hepatitis B virus. Give 3 examples of how normal innocuous substances may cause here hypersensitivity, and we talked about that, how here pollens, for example, or and usually those are small, have small molecular weight, and then they bind to tissue, so they act as here a hapten, and then binding into a receptor on the hapten here where the reaction is going to take place. So small molecular weight, then allergens on their own, they cannot induce an immune response, but when they bind into a protein carrier here, then they will develop an immune reaction. Give 3 examples of how, yes, we talked about that, and contrast the 2 different skin tests here described in this chapter. We talked about the skin prick test for type 1 hypersensitivity reaction, and the patch test for type 4, the delayed type hypersensitivity reaction. So now we will go in more details about the types of hypersensitivity reactions, type 1, 2, 3, and 4. And we will talk in details about type 1 hypersensitivity reaction, which is the allergic type that is mediated by IgE antibody, or the anaphylactic type, we call it. So the main objectives then here at the end of this lecture, you should know the mechanisms of what we mean by the early and late phases of allergy. We'll see that type 1 hypersensitivity has an immediate here mechanism and signs and symptoms, and then we have a late manifestation, and we will see, and you should know the exact mechanism, what happens in the early and in the late manifestations of type 1. You need to compare the roles of T helper 1 and T helper 2, and here in relationship to the cytokines that are involved. And you will see that T helper 1 here is related to cytokines that are going to involve with more of cell-mediated type of a reaction, and T helper 2 with the immediate type. So you should know the cytokines that are present in T helper 1 and T helper 2, and how the products of T helper 1 can suppress products of T helper 2, and vice versa. The cytokines of T helper 2 will suppress T helper 1 to produce cytokines. We call that polarization. So it's so important to know the cytokines produced from T helper 1 and T helper 2. And then here we need to know or to describe here the immunological factors that predispose to allergy, and explain how these may be increasing allergy at a population level. We'll see what are the factors that will influence the genetic factor, environmental factors, for example, and so on. So you should know those in details. And also, you need to describe the techniques used to identify here allergen involves in the immediate hypersensitivity reaction. And we talked about the skin prick test, for example, here that is involved. And also describe here anaphylaxis, anaphylactic shock, and its immediate treatment. So this is one of the emergencies in medicine. So when I say anaphylactic shock, what's going to happen? And you should know the immune mechanisms that is involved, and how we are going to treat that, and what really makes our blood pressure to fall down, and then what are we going to do as an emergency treatment. List the modes of action of drugs here used to treat allergy. So you have to know all the drugs that we use for the treatment of allergy, because those are life-saving measures, because patients, they could die here if they develop anaphylactic shock. So what are the drugs that we use and how we are going to use them? And you are going to be asked about those in immunology as well as in medicine in general. So certain terminology and mechanisms you should know in type 1 hypersensitivity reaction. What do we mean by atopy and the atopy genes that are involved? حكينا about the genetic susceptibility to develop type 1 hypersensitivity reaction. We call that atopy. So it is an inherited predisposition to this type. Very, very important to know. And how the hygienic environment, they are more susceptible, and the patients that are living in a very clean and superstitious about dirt and so on, those are highly susceptible to develop type 1 hypersensitivity reaction. We will see why this mechanism that we call the hygiene theory, and how the T helper 2 cells are the ones that are involved, and how these cytokines that are going to be produced here favors the production of IgE antibodies and eosinophils at the same time. And then when IgE antibodies they develop, they do have receptors for the Fc portion of the IgE antibody on mast cells. So mast cells, they do have receptors for the IgE antibody, and then when they are exposed to the allergen, cross-linking is going to take place, and then they are going to degranulate. And so the granules and the mediators in the granules are going to induce the allergy signs and symptoms. And you should know all the diseases that are associated with type 1 hypersensitivity reaction, the rhinitis, or what we call allergic rhinitis, or the hay fever. This time of the year, everybody sneezes, running nose, and so on. Bronchial asthma, where they have shortness of breath. Bronchoconstriction, where they cannot breathe. They have narrowing of the bronchioles and wheezes, sidr musafir, and so on. We call that bronchial asthma. And some people will develop anaphylactic shock and anaphylaxis. And what's the mechanism of anaphylaxis as type 1 hypersensitivity reaction, and how to reverse that. And also certain types of skin diseases, or dermatitis and eczema, that are associated with the immediate type of hypersensitivity and the IgE antibody that is involved. So here we have certain terminology and definitions, as we said, related to type 1 hypersensitivity reaction. It's extremely here to know that type 1 hypersensitivity reaction usually occurs in the hygienic environment, or in a very clean environment. This is going to favor the stimulation of T helper 2 cells, and the T helper 2 that are going here to induce the B cell to produce IgE antibodies. So usually they happen in a hygienic type of an environment, the IgE antibody response. And as I said, you should know the diseases that are involved. The most dangerous and life here threatening is the anaphylactic shock and death, but others also are important, and they could lead to death, like bronchial asthma, for example, allergic rhinitis, very important, and so on. You should know all the diseases that are associated with type 1 hypersensitivity reaction. So those patients that they develop those diseases have a history of atopy. That means they have the genetic susceptibility to develop type 1 hypersensitivity reaction and IgE antibody response. So they carry the atopy trait genes, and then they are more susceptible to develop these allergic here manifestations of the diseases. The ultimate, or the most serious of these types of diseases, are the production of anaphylactic shock, which is here manifested due to the mediators that are produced. Here leads to hypotension here, and then death will be associated with that. So I want you to remember here the anaphylaxis that could lead to death. Also, the angioedema, here sometimes where those types of diseases will lead here to swellings, edema of the lips, tongue, for example, nose, and so on. We call that angioneuritic edema, or what we call urticaria, where we are going to have skin rash, edema here at the skin, and itchy to the skin. So itching is so important. Also here bronchial asthma is very important. Allergic rhinitis, very common, hay fever this time of the year. Bronchial asthma could lead to death when the patient develops what we call status asthmaticus, and continuous here narrowing of the airways, or could lead to obstruction, suffocation, and death. And of course, eczema, skin lesions related to type 1 hypersensitivity reaction. So it is so important then here to differentiate between allergies and other clinical conditions. Why? Because sometimes the treatment could be different. So if the patient is having a skin rash and so on, you should know, you have to make the diagnosis because your skin rash might be caused by many other diseases. So you have to make the diagnosis to start with before you start thinking that this is an allergy and give anti-allergic medications. And you should know that in type 1 hypersensitivity reaction, we have an immediate response related to IgE, antibody contraction of smooth muscles, and so on. And then the late manifestations related to the production of eosinophilia. And we will see that the eosinophilic response could lead to tissue damage as well. So when you see eosinophilia, this is a late manifestations of type 1 hypersensitivity reaction. And you will learn in medicine how to check for these eosinophils, for example, in what we call charcot-Leydig crystals and the products of these eosinophils. So type 1 hypersensitivity reactions, as I said, they could be related to many triggering conditions like drugs, like penicillin, for example, could lead to anaphylactic shock following a previous exposure and then sensitization to the patient. And some patients, they could inhale pollens of plants and develop allergic rhinitis. Very, very important here to know. Some people are exposed to, they inhale fungal spores, and they could develop bronchial asthma, for example, associated to that. Or sometimes people could be allergic to feces of certain insects, and house dust mite, for example, in old homes and so on, and they could develop bronchial asthma related to that. Some people, they could be allergic to insect venoms like honeybees, for example, and could develop anaphylactic shock in certain patients. And some people, they could be allergic to beta-lactam antibiotics, and they could develop what we call cross allergy. And cross allergy here, we mean by that, if the patient is sensitive to penicillin G, which is, for example, a beta-lactam antibiotics, could, it's not necessary, but could be allergic to cephalosporins. And we could, because they have the beta-lactam ring, so they could cross-react. We call that cross-allergy. So patients that are allergic to penicillin, they could be allergic to cephalosporins, and they could develop what we call cross-allergy. And many patients, they have died because of this cross-allergy here conditions. So this is a clinical case about here latex hypersensitivity or allergy, and here it will show that certain patients, they could develop hypersensitivity reaction to allergy, to pollens, to latex. So here, when you are using gloves, for example, that latex gloves, and then you test for, or when you examine a patient, touch his or her tongue, for example, lips, if you are a dentist, something like that, an allergy could develop, and the patient could have the wear and flare type of reaction, edema, and so on. Like in this case, when the patient did the skin prick test, for here certain types of food related to latex, like for example, kiwi, bananas, and so on, where the patient is allergic to those as well as to latex. So as a dentist, you should you should know here that allergies or hypersensitivity reaction of type 1 here could be related to latex. So when you are having gloves, here for dentists, it's preferred to have latex-free particles, and those they could be more expensive. So they should be available at least. So when the patient develops allergies, you should change those gloves to latex-free. So it's so important for dentists to know this fact and to test their patients for allergies related to latex, and then if any of those patients is allergic to latex, because this is in minutes, you should know that. Then you should change these gloves into latex-free gloves. This is another clinical case about peanut butter allergy for a child, and how he developed type 1 hypersensitivity reaction. Just read this case in details, and then apply what are the mediators are going to be released, and how IgE antibody is the one that's responsible, and how we can detect this IgE antibody in the lab. So read it carefully, and then apply all here what we have learned about type 1 hypersensitivity reaction from this case. So this is what's going to happen. You can see a mast cell that has just arrived, that has an Fc receptors for IgE antibody, and when the antibodies has developed, they will bind to their Fc receptors, as you can see. And any Fc receptor for an IgE antibodies, I mean any IgE antibody, can bind to its receptor with many different specificities. And here, when this patient is exposed with this specificity, for example, to peanut butter, a cross-linking of those IgE antibodies are going to take place. And when IgE antibodies cross-linked with the allergen, like peanut butter here, for example, here a degranulation is going to take place. And so the mast cells degranules, so they release the mediators of inflammation that causes smooth muscle contraction, for example, many chemotactic factors, and so on. So here the most important thing to remember, that any Fc portion of an IgE antibody, irrespective of its specificity, here it is, for example, for peanut butter, it's going to bind. And then cross-linking here of the peanut butter to the IgE antibody will cause the degranulation, and then the inflammation that will follow. So here the systems that's going to be affected by type 1 hypersensitivity reaction could be systemic, or the anaphylactic shock that we have talked about, that is manifested with low blood pressure, and then shock, and of course angioedema, for example, airway obstruction can be fatal, of course, suffocation, shock, and death. So allergies to nuts, for example, or penicillin sometimes, anything could lead to what we call anaphylactic shock and death. Or, for example, you could have a bronchospasm and airway obstruction, and could this lead to suffocation and death in the status asthmaticus, for example. This is in bronchial asthma. Or, for example, if in the nose, we call that allergic rhinitis. So this is usually a reversible airway obstruction, so it will last for a certain period of time, and then if medication has been taken place and usually it recovers without a sequelae. The allergic rhinitis is just a discharge of the nose, sneezing. Like this time of the year, you'll see many people, they are coughing and sneezing. And the skin, you will see allergies, itching, I mean, just itch and edema, usually of the cutaneous lesions of or anatomical areas of the skin. Or what we call angioedema, same thing here, edema associated with itchy edema of the subcutaneous skin part, or what we call atopic eczema, which is a chronic itching inflammation of the skin, and some cases are caused by food allergies. Sometimes could be responsible for this type of an eczema, we call it. So the role of antigen presenting cells, then they play a major role in what we call the polarization here of the T helper cell. And as you know, we have T helper 1 and T helper 2, and the T helper 2 is the one that is responsible here for the production of IgE antibody, while T helper 1 is usually suppresses T helper 2, for example, and vice versa. T helper 2 is going to suppress T helper 1. So the polarization then for the changes of from T helper 1 or to helper 2 cells has to do of how the antigen is going to be presented. So the antigen presenting cell then here makes the major role in the polarization and changes for T helper 1 to T helper 2. For example, here the T helper 1, for example, BET will make the cell to activate the production of interferon gamma, T helper 1 activation, and so on, which is going to suppress T helper 2. While, for example, the Treg here, the T regulatory cells is going also to control this process through, for example, production of other cytokines. So the Treg here helps in the regulation of this process. So the Treg then is the one that plays a major role with the antigen presenting cells. You have to know the intermediate stages that will go through this process, that the production of GATA3 intermediate, for example, in the here the activation of the T helper 1 that is going to change into the make the cell to produce IgE antibodies. So the polarization then has to do, as I said, with the antigen presenting cells, and you should know the intermediate stage for the T helper 1. We call it T bet, for example, and for T helper 2 is the GATA 3, for example. That's going to make changes for the production of IgE antibodies, while the T helper 1 is responsible for the production of interferon gamma and others that are going to suppress T helper 2, and vice versa. This is so important to know. Then the process of polarization is then extremely important between T helper 1 and T helper 2, and you should know all the intermediate stages here that's going to go in between. Like, for example, other here cytokines are going to be produced that are going to affect, for example, the production of eosinophils and other mediators. Like, for example, here the eotaxin, for example, attracts eosinophils and T helper 2 cells here to the site of inflammation. So when T helper 2 is activated, you will see eosinophilia that is going to be produced, and also interleukin 4. And interleukin 4 also are going here to stimulate here B cells to give IgE antibodies. So you can see eosinophils and IgE antibodies that are going to be produced. And at the same time, this is going to suppress here the T helper 1 when T helper 2 is stimulated. And it is so important here to know that at the same time, interleukin 5 are going to be activated, and interleukin 5, for example, they are required for the production of eosinophils. So here, remember interleukin 4 and interleukin 4 for the production of IgG antibodies, interleukin 5 here for eosinophilia at the same time, and the regulatory cell here, we call it, or the cytokines here that's produced, we call it interleukin 10. And the interleukin 10 here switches of macrophages. So the going on and off the regulatory Treg, we call it, through the production of interleukin 10. So remember interleukin 5 and its relationship to eosinophilia, interleukin 4 with IgG, IgE antibodies from B cells, and the eotaxin, for example, also responsible for the eosinophilia production. So all of those intermediate stages and cytokines and their function is so important for you to know. So the granulation process and the granulating cells then that are present within the mast cells here that are present in tissues, and some they reside there. They have Fc epsilon receptor 1 with high affinity, and the IgE antibody Fc receptor is going to bind there, and other activating agents that are involved here. Like, for example, temperature changes. We call that cholinergic urticaria, where some people, for example, when they are exposed to cold, then this is going to cause degranulation of mast cells, and then they produce those inflammatory mediators. This is so important to know. So it's not just the binding to an allergen that's going to trigger the mast cells, but also changes in temperature, like in cholinergic urticaria. Also, the eosinophils that are produced in reference to interleukin 5 and interleukin 13, they are attracted to site by the eotaxin. Remember the interleukin 5 and interleukin 13, for example, and their role in the eosinophilia. The basophils also, they are going to be activated and called into the area as well. And the antibody that is produced from those B cells is the IgE antibody class, and through the interleukin 4 it's going to switch into the one that produces the IgE antibody. So interleukin 4 that's produced here is responsible for the switching process. The T helper 2 then, under the influence of interleukin 4, then is going to switch to the production of IgE antibodies. So the skin prick test, for example, that we do, here we are going to induce the production of eosinophilia, and you can detect that with ELISA as well. So remember that T helper 1 and T helper 2 polarization, then activation and suppression, those they are opposite to each other. So the products of T helper 1 will suppress T helper 2, and vice versa. The products of T helper 2 will suppress T helper 1. So it's so important to know then in this process. So the T helper 1 and the T bet, for example, here their products like interferon gamma will suppress T helper 2, and T helper 2 for example will suppress T helper 1, and so on. So the intermediates that are going to be produced, for example, like the GAT A3, that's going to produce interleukin 4 and interleukin 5 for the eosinophilia, and interleukin 13. So this is what we call a positive feedback. So that Treg cell, the T regulatory cells that produce the interleukin 10, for example, or the transforming G F beta, for example, those are responsible, that are produced, from the antigen presenting cell here, like for example the stimulation of the toll-like receptor 2 is going to activate this to produce those cytokines and change into the GATA 3 intermediates, for example the production of interleukin 12, for example, and interferon gamma. So what really then triggers the production of IgE antibody, or switching into, for example, interferon gamma, here has to do with the genetic factor, as well as I said environmental factors, like here some of the genetics related to a substance, we call it filaggrin variants, and this filaggrin, for example, is responsible for the role of the epithelial layer of the skin, for example, has a positive role. The lipopolysaccharides, for example, while, for example, in livestock, exposure has a negative effect. So the more dirty the environment, that's going to suppress the T helper 2 and activates T helper 1. Cat exposure, for example, some are positive, some negative. Rhinoviruses have a positive effect, for example. So then the role, I want you to remember the polarization here between T helper 1 and T helper 2 and the factors that are going to be involved in this process. Genetic factor and environmental factor at the same time, and the role of here the Treg here in this process. So the predisposition then to allergy has a genetic factor and then an environmental factor at the same time. So it is so important for you to know this fact. So the prevalence of the rise in the type 1 hypersensitivity reaction, like for example for peanut allergy, then has to do with genetics and environmental factors. So important for you to know this fact. So genetics and environment. For example, in genetics, the history of atopy, for example, is inherited. The atopy trait, for example, 40% here in the West, Europe and the United States, has this trait. So they are more susceptible here to type 1 hypersensitivity reaction. And we see that it runs in families, or brothers and sisters. Usually they share this trait, they become allergic. So here then, if the trait is inherited, then you have to know that family members, they could carry the same gene and they could be allergic. So in twin studies you can tell here that this trait, for example, runs in that particular family or not. Polymorphism, for example, we could see it in interleukin 4 or in the Fc epsilon receptor 1 with the high here affinity here agents that could bind into those. More usually we see that in the mother side rather than in the father's side. So the filaggrin then, that is responsible for making a tight here junctions in the epithelial layer of the skin, sometimes could have variants that could play a role in that. For example, usually we see that in more superficial filaggrin forms, because this is going to cause natural moisturizing factor of the skin. While, for example, here in the deep layers of the skin, filaggrin contributes to tight junctions, so it makes it more dry and less sensitive. So filaggrin helps then to maintain the cutaneous barrier and its moisturizing ability. So this is again then the polarization then between T helper 1 and T helper 2 is extremely important to know here, and the role of the Treg in this process. And they have noticed that here the environment that is more dirty here favors more of T helper 1 polarization and less T helper 2. That means here people that, for example, are living in farms and so on, they exposed to fecal material of cows and so on in a dirty environment, and those they could have Mycobacterium tuberculosis as well, that could induce or stimulate T helper 1 activity. Here this is going to suppress T helper 2, while in a clean environment and so on, this is going to suppress here T helper 1, of course, and activates T helper 2. So the hygienic then phenomena in hygienic environments, they are more here susceptible to allergies compared to less hygienic environments. So this is so important for you to know. So ones that are working in farms and so on, less likely to develop allergies of type 1 hypersensitivity, and vice versa. So this is so important here to know. You can see in this slide the hygienic theory, the hygiene theory, high levels of T helper 1 here in less hygienic environment, which is going to suppress T helper 2, and vice versa. In a clean environment, this is going to activate T helper 2 and suppress T helper 1 activity. So again, then about the hygiene hypothesis, remember, and less hygienic environment, more of type 2 here polarization, and less hygienic, more polarization to type 1, T helper 1 cells here. So you should know here the hygiene hypothesis theory, and the sometimes changing of the environmental factors that could play a role. For example, the chemical pollutions, for example, will helps the polarization to T helper 1. For example, ecological here changes in the environment. We see it in more cleaner environments, or growing in farms مثلا is less, because this is going to suppress T helper 2. For example, none we see in TB areas, because this is going to favor T helper 1. Non virulent strains, for example, of Mycobacterium here switches to T helper 1. So we could do that, for example, to favor the Treg production. So here some people thinking of vaccination with Mycobacterium vacca, for example, as a treatment of allergies. So they will suppress here T helper 2 cells and activating T helper 1 cells. Some suggested using medications, drugs, like for example what we call a CPG, that activates the toll-like receptor 9, that's activate interleukin 12, for example, that will help here in this polarization step. So again, then this the effect of the cytokines that are produced from T helper 2, that are responsible for smooth muscle contraction, for example, and cause of bronchial asthma, as well as the secretion of a mucus from goblet cells. So T helper 2, for example, will cause more secretion of a mucus and contraction of smooth muscles. And this is going to be responsible, as I said, for the bronchial asthma symptoms. So it is so important here to understand then the role of these cytokine mediators here in the pathophysiology of bronchial asthma. So it is so important then to know the effect of T helper 2 stimulation, and when they migrate to the bronchial tree, what's going to happen. Just as I said, narrowing of the bronchioles and wheezes, which is the pathognomonic for bronchial asthma, and secretion of mucus, as you can see, which could block as well the airway entry, so smooth muscle contraction, and here mucus production, as well as eosinophilia. And this is, we see it in what we call the late manifestations. So in the early manifestations, it is the smooth muscle contractions and so on, but in the late manifestations, when eosinophilia is produced, as I said, more of broncho constriction, more mucus thickening, and a blockage of the airway entry. So this is extremely important then to know about the early stage of the type 1 hypersensitivity reaction and the late manifestations. The early is related here to the immediate effect, which could cause bronchospasms, as I said, and due to the production of prostaglandins and leukotrienes, for example, and this is going to have vasodilatation and drop in the blood pressure, and then the allergic rhinitis that we see, sneezes and coughing and so on, mucus secretions as well, and then we see that in bronchial asthma, mucus secretions, smooth muscle contraction, and wheezes. And this is going to continue as long as the allergen is present. Here, when eosinophilia is produced, here the eosinophils, they have many mediators that are going to inflict more injury, and this is going to be responsible for what we call the late phase of the reaction. So in the late phase, we see it occurs hours after the improvement of the early phase, and this is responsible mainly because of the eosinophilia that are going to be produced. So the eosinophilic, the eosinophil mediators, like for example the peroxidases, major basic proteins, and the cationic here proteins, those are the major manifestations of the related to the late manifestations of this reaction, and this is going to inflict here damage to tissues. So we see a chronic then allergic inflammation, smooth muscle hypertrophy, for example, and mucus secretions that leads to airflow a blockage. So sometimes the late manifestations could be as serious as the early manifestations. So the treatment of type 1 hypersensitivity reaction is not just as certain people would say, just will give antihistamine, because histamine is one of the mediators that are going to be produced. So one here agent might not be enough, and usually it's not enough. So the drug of choice that we need to use are corticosteroids as mast cell stabilizers, and the one that is saves lives is the catecholamines, or the epinephrine, adrenaline, and noradrenaline. So epinephrine and the beta 2 adrenergic here agonists here inhibits the effect of mast cell mediators, and this is the one that is going to save lives. I want you to remember that. So emergency treatment for any of those related to type 1 hypersensitivity reaction, like anaphylactic shock and so on, is the catecholamine, adrenaline, and noradrenaline, or what we call epinephrine, and beta 2 here adrenergic agonists. Some people, they try to use leukotriene and histamine receptors blockage, but as I said, this might not be enough because of other mediators that are produced. And of course corticosteroids that will inhibit the synthesis of mast cells, here mediators. And also we have the chromoglycate as well, will stabilize the mast cells so they won't be degranulate. So remember then, the epinephrine, or epinephrine is the drug of choice, and then followed by corticosteroids. So here, for example, some of the insect venoms, like the bee venom, could cause anaphylactic shock. So they have noticed that when the bee's venom is injected cutaneously, for example, like in here, this is going to stimulate T helper 2 cells rather than T helper 1. While if the venom is injected subcutaneously, it is going to induce T helper 1. So in order for the desensitization to take place against the bee venom, it has to be injected subcutaneously. So more of T helper 1 is going to be stimulated. That's going to suppress T helper 2. I think this is so important for you to know. So the treatment of type 1 hypersensitivity reaction has to do with the main etiology, avoidance, if that is possible. And here we so in the treatment, then as I said, when we have a wide range of symptoms, and we have to alleviate the symptoms. We have to avoid, as I said, the being exposed to the allergen as much as possible. Can we change the genetics sometimes? Yes, by some people that are allergic to the fur of cats, for example, they can change that genetically, but this is so expensive. Here, like certain cats that they don't produce these fur, for example, we call them the Phil D1. Those are genetically engineered, that are so expensive here. But the best thing to use are drugs. Here, like the beta-2 adrenergic agonists, for example, like the salbutamol. And this is the drug of choice that we use for the treatment of asthma. Selective beta-2 adrenergic agonist. But the emergency medication, here we use the epinephrine. Here it's life saving here in anaphylaxis, and if we don't give here adrenaline, for example, the patient could die. So antihistamine is a weak choice of treatment, as I said, because it's not just histamine that is involved in these mediators. They have tried the receptor antagonists, for example, the Montelukast here, but some they say that it is that effective, but nothing compared to others. Corticosteroids here prevent the early and late phase of here reaction. So corticosteroids, it's a must in the treatment of these types of allergies. Sodium or chromoglycate can stabilize mast cells like those of steroids. T helper 2 cytokines, here pathway blockers, tried those, but not that effective compared to the ones that I have mentioned. IgE receptor blockers as well, it can help. So the process that we use nowadays, we call it desensitization or hyposensitization. And this method is very effective, but only if we are dealing with a single agent. So here the idea is to stimulate the production of T helper 1 over T helper 2. T helper 1 activation of the Treg, and this is through the route of injection, as I said, by subcutaneously rather than intradermally. So in latex, for example, allergies and peanut allergies, at least the patient has to know that he or she is allergic to latex, and change that with latex free, as I said, gloves, for example, or media in general. And of course the same thing here with peanuts, peanut butter, where the peanuts sometimes could cause suffocation and death related to the allergies that it could produce. So the test that we use to make a diagnosis of allergy is the skin prick test. In the skin prick test, you draw a map on the patient's skin, and you put positive control, negative control, and then test here for many different antigens or allergens that you expect the patient is allergic to, and you compare that with the positive control, and usually you can see that within 10 minutes, here maximum within an hour or two, here to see the reaction, the well and the flare type of reaction, edema and erythema here associated with that. So here the skin prick test then here stimulates the pathophysiology of type 1 hypersensitivity reaction. So here when you inject the allergen, then it's going to stimulate, as I said, here mast cells by cross-linking the IgE receptor, so cross-linking, and then degranulation of mast cells are going to take place, and then mediators are going to be released, and then you'll see vasodilatation and edema here. So you can see the edema, erythema here of the skin test, and itchy, of course. So the erythema and edema, sometimes you could see that in the conjunctiva as well. So in many of those allergic conditions, you can see here erythema of the conjunctiva, red eyes, and sometimes you could see as well edema of the face associated with this type of allergy. And this is, of course, going to disappear when you use the catecholamines or adrenaline and corticosteroids here effect. So this is the allergic urticaria. You can see the edema of the skin associated with type 1 hypersensitivity reaction that is so itchy here, and when you use the corticosteroids or the adrenaline and so on, then it's going to disappear. So when I say urticaria here, I'm referring to the edema to the skin that is manifested with the type 1 hypersensitivity reaction that could be associated with change of skin temperature, like one we call it cold urticaria, for example. And the same thing here, you could have what we call a skin eczema. It's type 1 hypersensitivity type of a reaction manifested with erythema, itching and edema, severe itching to the skin. That could be controlled, as I said, also by corticosteroids here treatment.